Hello and very welcome and good afternoon and good evening to everybody. Um, you're very welcome to this European Wound Management Association webinar on the topic of palliative wound care and with a specific focus on symptom management and emerging interventions. Thank you to all of you who have registered, and just a reminder that this will be available for download afterwards. I'm very honoured and proud to be welcoming our two co-presenters for today, Professor Sebastian Probst from Geneva in Switzerland, who is a past president of EWMA, and Dr. Elena Conde Montero from Madrid, who is currently the honorary secretary of EWMA and is also a dermatologist. And they will be presenting later on in the session. I want to present on the overall document, which some of you have now become familiar with. And I suppose just to give you an idea of a little bit of the background of the document and where it has come from, it came out of, I suppose, much discussion around palliative care, much discussion around palliative wound care, what it is, and who it serves. And we know, for example, that over 56 million people require palliative care in its broadest context globally, but yet only about 14% receive it. And sometimes I think for us, particularly in many of the European countries, it's hard for us to constantly remember, we are so privileged in what we receive and that it's not always available to everybody else. The focus is mainly on symptom relief and quality of life across healable, maintenance and non-healable wounds. The document was developed in collaboration with the European Pressure Ulcer Advisory Panel, the Wound Healing Society and Wounds Australia. And there's a list there of the author group, and we want to thank and acknowledge all authors for their huge contribution to this document. Also, we just want to acknowledge our industry sponsors who provided unrestricted education grants for the document, and these include Convatec and Hartman, and we just want to acknowledge them. The document itself is divided into various sections. We will deal with most of them today. We probably won't deal with the last one, even though it is inherent in much of what we will be presenting. So we're going to look first of all, and very briefly really, on what we mean by palliative wound care. How do we define it? And then we'll look at some of the major topics such as pain management, odour management, exudate management, bleeding, the peri-wound area, pruritus, nutrition, and then some, as I say, person-centred approaches will be integrated throughout. So just to give you a brief overview as well, I'm going to present to you next on what we understand by the concept of palliative wound care, and also how the content of the document was informed by an international survey. I'll hand over then to my two colleagues who will deal then with the major symptoms, and then we'll have time at the end for some questions, about 10 minutes approximately. So if you have questions, please feel free to put them in the chat, and we'll try and take them from there. So what is palliative wound care? It's one of those that it seems obvious to many people, but actually when we look at definitions for palliative wound care, definitions for many other concepts, we find that there are differences geographically and also differences by speciality. And what that means is that when one tries to look for resources to support something like palliative wound care, the definition that's used can influence not only the resources, but who provides the resources and also the access to resources. So what might seem like an academic exercise has actually huge implications, particularly for patients. So we set about trying to define this concept. And I suppose our starting point was what the World Health Organization definition of palliative care was. And they said that it's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial and spiritual. So the emphasis here is on quality of life, but also on life-threatening illnesses. But specifically, it does not mention end of life. So how do we define palliative wound care? So I'm not going to go into the entire how we did it, but we conducted with an international panel a scoping review. And in that, we looked at how it was defined within the literature. And we found over 2,500 records. And of the analysis of those and refining it down, 133 were included in the final data synthesis, which in terms of scoping reviews is actually a very significant number. And the result of this is a paper that is published in Journal of Tissue Viability, led by Dr. Dewey Gusejian. And the definition that we have is that palliative wound care is person and family centered, holistic and interdisciplinary care of wounds that may heal or not, or may be too onerous to treat, including but not limited to symptom control and management for individuals who are often vulnerable and have impaired quality of life. And interesting in this, when we looked at how palliative wound care was referred to within this, we wanted to see what type of wounds they were often referring to. And what was interesting, and I suppose what was rewarding, was that it referred to a huge array of wound types. The most of those were malignant fulgating wounds and pressure ulcers. And we'll see that that's reflected later on in our own survey. The definition we have also is very much aligned with the World Health Organization definition. So that is good because it means that we're not at odds with what is accepted terminology. As I mentioned, we conducted an international survey just to inform the document and to say, are we going to address the things that people actually have as a problem? Are we addressing the needs of clinicians and others? And what was interesting was when we asked people, what were the most frequent wounds you encounter that require a palliative approach? And of all of them, pressure ulcers was the most common. So when we looked at the definition, pressure ulcers and malignant fungating wounds were the major wound types. But as you can see here, pressure ulcers was the most common, followed by fungating malignant lesions. And we asked them then, what were the challenges that they faced? What were your top 3 challenges? And what were your top 3 concerns for your patients? And they come up with the same topics again and again: pain, odour, exudate, infection prevention, psychological concerns. So that these, particularly the top 3, pain, odour and exudate, they come up no matter which way you ask the question. They are the major concerns that patients have. When we asked what were the priorities for research in this area, they said symptom management, which of course would include pain, odour, exudate, patient-centred approaches, innovative dressings, guidelines and protocols, education and training. So I think what the document and what the authors have tried to do is not only to go off on our own and say, this is what we think is important. We have asked people, what are the things that they see as being important? And we feel that the document goes in some way towards addressing that. So in summary, we would say that palliative wound care is not limited, is not time limited, and is focused on the patient and family goals. The concept of it can guide policy, resources, and services. The major symptoms, as we know, are pain, odour, exudate, and bleeding. And it often differs from general wound care in many areas, but particularly for the outcome of healing. And we do say that there is a critical need for research to develop this area of practice. But I think the response we've had from today shows that there is a huge interest in that. So I'm going to hand you over now to my colleague Elena, who's going to take it from here. So I'm going to stop sharing my presentation and allow her to share hers. I'm also going to mute my audio, and just a reminder in case anybody has not done so far to just mute yourself. So thank you very much for your attention.
Thank you, Georgina. It's a pleasure for me being here with you talking about such an important topic. And well, as Georgina said, we normally talk in palliative care about pain, about odour, exudate, but what about pruritus? But well, as we will see at the end, well, or during the presentation, pruritus and exudate are very linked, and also to bleeding to other symptoms. And what is pruritus? Pruritus is a very unpleasant sensation. It's something that not only affects the patient, but also the caregivers. In fact, it affects the sleep, well-being, and sometimes the patient tells us, "Oh, I mean, this is very itchy," and we just tell him, "Okay, some antihistamines," which will not help, as we will understand during this presentation. So it is not only something that is underestimated in palliative care, but it is also poorly treated. And what about the literature? What has been described on pruritus in palliative care? Well, pruritus in wound care has been described mostly in other kinds of wounds and mostly in burns, in scars after burns, which are very itchy. But if we go to wounds in general, well, look at this prospective study with different wounds of different etiologies, and itchy wounds or itchy lesions will be found mostly on the lower limbs, will be mostly venous ulcers, and they are normally large wounds, and necrotic tissue is associated to pruritus, also granulation tissue. And if we go to palliative care, as I have said regarding palliative wounds, a few studies have been published, but pruritus is there. It's a symptom that patients suffer from, and malignant fungating wounds are one of the main etiologies. And something interesting, duration is not predictive for itchy wounds. I mean, even in an acute wound can be very itchy, and a long-standing wound too. And what about the physiopathology of pruritus? If we had to sum it up, it's very complex, but we could associate it to pain. They have very similar, in fact, they share pathways. So we could say that pruritus is a pain-like phenomenon. And before continuing, when talking to patients, it's better not to talk about pruritus. We just ask them if it's itchy, okay? So, because some of them won't know which is pruritus. So this is a scheme of what happens when our wound or the perineal skin itches. So these are the players there. So this is a neuroimmune pathway. So we have two mechanisms. One is the inflammatory mechanism with these molecules, cytokines, interleukins. Histamine is there, but it's not the main player. That's why antihistamines won't be the drugs that will be first line for pruritus in this kind of situation. And these substances activate C fibers in the skin, and then we have the activation of the pathway. But we can also have spontaneous discharges, these burning symptoms, these stinging that patients tell you. This is called neuropathic. This means that we have both inflammation and nerve damage that is involved in pruritus. So to make this simple, we have the problem in the skin as if we had a trauma. So this is similar to pain. Then the signals go to the dorsal horn in the spinal cord, and then we have other neuromediators, receptors that activate the pathway, and then this goes to the brain, and we can scratch. So this is very complex, but at the end, it's quite similar to pain. That's why the drugs I will talk at the end of the presentation are also used for neuropathic pain. So neuropathic pain and neuropathic itch are quite similar, both in pathophysiology and in treatment. And which is interesting for us is that we have inhibitory and excitatory pathways. There are things that activate and others that inhibit this pathway. So we can control pruritus. And it's very important to know that cold inhibits itch. That's why when we do cooling strategies on the peritoneal skin, patients will really appreciate it. And today in Madrid, it has been snowed. It's very appropriate, that slide. So the first thing, if we want to attack pruritus, is to know why the wound and the peritoneal skin is itchy. So peri-wound skin can be the problem in most cases. In fact, it's quite frequent to have the pruritus in the peritoneal skin, not in the wound. So this is a short reminder of what is the skin. We are going to focus on the upper layer of the epidermis, which is a layer of dead cells that I love this. I mean, to talk about the stratum corneum as bricks with cement. In fact, we have dead cells that are covered with lipids. This is a hydrolipidic barrier to protect us from the exterior. So what happens when we have a wound? That the peritoneal skin will receive metalloproteases that are in the exudate that will destroy this perfect wall that is protecting us. So those bricks and those cement will disappear. But not only exudate, but also those dressings that we put on and donning and doffing, removal of dressings will take these cells, this barrier away, and we are going to lose water. Our stratum corneum, those dead cells with lipids, are prepared for our skin not to lose water. So you can imagine why peritoneal skin is normally like this. It's not. It's a disrupted barrier that can be very dry, just because we are losing this protection. So what are the consequences of this? So we can have eczema. This is very itchy, and now we understand why eczema is itchy, because inflammation. When we have inflammatory mediators, the pruritus pathway will be activated. Just for you to know, eczema is a synonym of dermatitis. So we may have dermatitis of different causes. So this is quite common in wounds where we are not controlling exudate, but not only dermatitis, but also maceration. When we are giving too much, we are overhydrating the peritoneal skin, this skin and these cells, these bricks that are there will be disrupted. So at the end, we are going to have also a barrier disruption. And this is very common in palliative care, not only because the wound is palliative, but in people that are bedridden with incontinence or in a wheelchair. And the problem is not only these lesions secondary to moisture, but this makes the skin to be prone to infections. And the most common is candidiasis. If we control inflammation with the strategies we are going to talk about later, we can also reduce the incidence of infections. And look, just for you to know, when should we suspect candidiasis in the peritoneal skin? Look at these punctiform pustules in the perilesional erythema. Erythema is normally whitish, shiny, and then we see these point-sized pustules. This is the clinical sign to suspect candidiasis. And another pearl, when we see this dermatitis around the wound, we normally think, oh, this is an allergy. Okay. As we said before, dermatitis is eczema, but allergic dermatitis is not very common. The most common contact dermatitis is irritant dermatitis, eczema due to excessive exudate, but allergic dermatitis is not the most common contact dermatitis. But in palliative patients, in those patients with wounds that will be there for a long time, this skin, as we said, this skin barrier around the wound will be prone to allergies, not only to dressings, but to other products. that we use and look at that list, even corticosteroids can produce allergic dermatitis. So just to keep this in mind, but don't think that the first cause of contact dermatitis is allergy. Think about irritants. Okay, so let's talk about treatment. But as in wound care in general, first thing is identifying the cause and treating the cause, isn't it? Well, in palliative care, something is also very important. Obviously, this is a framework that you will find in the document. You will have to evaluate before deciding the best management. But explanation makes the real difference, not only for the patient, but also for caregivers, and it will help to reduce stress. If the patients and caregivers understand the reason of the symptoms and how they can prevent or treat them, they will feel more comfortable. So this is the most important part in palliative care. And so, as we said, that in general, pruritus was more frequent in lower limbs, and it was associated to edema. It's easy to think that if we have edema, let's reduce edema, and we have different types of compression devices to adapt it to the patient needs. Okay, so in theory, this is fantastic, but this is real life in palliative care. Oh, look at this. This is phlebo lymphedema, and this would be healable wounds. In fact, we put compression therapy, legs elevated at rest. So why am I showing this to you in a palliative care webinar? Because the situation is this. This patient cannot be at home with elevated legs. She has obesity, she is in a wheelchair, she is oxygen dependent. So at the end, compression therapy may help, but at the end, it's not controlling, exudate is not controlling it. The legs are all the time like this. So with her, it's not compression therapy what will help us to reduce edema. It's just with her, we use wraps that will help us to reduce edema, but then elevated legs without anything to control maceration. Then we mix zinc oxide and corticosteroids to help to reduce inflammation too. So you have to adapt to the patient, and things that you would think, seeing the picture of the wound, okay, I can heal this very quickly. At the end, is the complexity of the patient that makes these wounds palliative. So let's continue. We have talked about reducing edema, adapting to the patient, and when you think about compression therapy, also with elevated legs at rest to have success reducing edema. And what about cleansing perilesional skin? It's important to do it in a gentle way and avoid friction. If you start cleansing with friction, you are going to destroy this hydrolipidic barrier and you will do more harm. So that's essential. And be careful about natural products. Some patients tell you, doctor, I prefer natural soap. Natural soaps are perfect normally for cleaning your clothes, but the problem is that they are strong detergents that will destroy this wall with bricks and cement with this hydrolipidic barrier. So in palliative care and in skincare in general, just recommend products that are called Syndet, or products that are in the market for cleansing the skin have synthetic detergents. This means that they will help you to cleanse the skin, but without destroying this hydrolipidic barrier, and they should be quite acidic to have the same pH as the skin. And as we have seen, the perilesional skin may be dry or maybe moist. So if you have moisture, think about powders, lotions, solutions, or maybe creams, but excipients that won't give more water to that skin. So afterwards, we are going to talk about corticosteroids, zinc oxide, products that you can choose different excipients, decide which ones are the perfect depending on the moisture or dryness. And if you have dryness, choose ointments, because this is a clear message. Our skin is our perfect natural barrier. And when we have a disruptive barrier, we have to give water and lipids to the skin, just to sum it up. And for you to understand what an emollient is, we need to give water to the skin and let the skin keep the water. So there are products in the cream such as urea and glycerol that are molecules that attract water. But we need this water to be kept in the skin. That's why we should use these emollients. Will always have Vaseline or other oils, and some of them will have ceramides and other lipids that will help to maintain the water in. That's why now we understand the ingredients of the emollients that you should recommend to your patients, and to reduce pruritus, no perfumes. And the less ingredients in the cream, better. And how do we reduce inflammation in this skin when we cannot control the cause? We cannot control exudate, as the patient I shown you. We cannot control incontinence. Corticosteroids are a perfect partner when you use them in an appropriate way. The reduction of this inflammation will prevent infections, as I've told you. And once you have infection due to excessive moisture, because Candida loves moisture, then put topical antifungals, but continue using corticosteroids. Because the problem of candidiasis in this perilesional skin with lots of moisture is not only the candida, but also the inflammation associated to candida. So think about combining both antifungal and corticosteroids to control this candidiasis in these moisture lesions. And what we are talking a lot about treating, but what about prevention? Which is the best barrier product for this perilesional skin? I've been searching if there are new studies published on this, but not really. And I show you this study. This is not a very new one, but here you can have the comparison of different products, barrier products. No one has shown superiority to others, but well, studies are not, we don't have high quality studies to have good decisions. But why do I choose in my clinical practice? This is a personal choice, zinc oxide paste. Because if I want to prevent, it's perfect because it will protect. But if I have dermatitis, if I have erosions, zinc is very interesting because of its properties of its anti-inflammatory, pro-epithelialization, and antimicrobial properties. That's why both for prevention and mixed with corticosteroids when I have eczema and other kinds of dermatitis in the perilesional skin is my personal choice. But as I have said before, no superiority has been proven, and you have to adapt your choice also to your patient preferences. And some people say, but Elena, zinc oxide leaves a lot of dirt around, and how can you cleanse it? I don't cleanse it. I just keep the zinc oxide there because it will continue having an action. Okay, if you want to get rid of that because the perilesional skin is dirty, don't use water. Use oily products, oily cleansers, because zinc oxide does not deal in water. And just to finish with two pearls, one regarding topical things that we can also do in the perilesional skin. As I've said before, if you can cool the perilesional skin when it is itchy, that's perfect. Levomenthol also helps in this cooling, with this cooling effect. Then you could use different anesthetics, and the final combination I show you there. Some colleagues that use it tell that it's very helpful. And capsaicin is very interesting because it acts like doing the contrary, creating lots of irritation, so that capsaicin creates a depletion of substance P, so the nerve endings of the skin won't have more transmitters to produce pruritus. So it's like irritating, so that you don't have anything else to produce it. So it's quite interesting too. And finally, when you have to use oral treatments, don't think about antihistamines as the first line drug to choose, because histamine is not the main molecule involved in this. Some antihistamines have sedative effect, so for that it may help, but not for the antipruritic effect, for the for the sedative effect, sorry. So the first line treatment will be gabapentinoids, or gabapentin, or pregabalin, and then there are antidepressants, opioid modulators, other drugs that you can choose. So I've shown you personal tips. There's not the perfect recipe for everyone. Patient-centered care is essential, especially for pruritus, and think in a holistic way to treat that itch. And I want to finish with this. This is my website. Everything I've talked about during this lecture is there. You can go for references and read more in detail. Thank you.
So thank you very much, Elena, for this presentation. And I will continue with some other symptoms. But before I continue, I would like to mention that you can write your questions in the Q&A section, and at the end, we will take your questions. So I will talk about the symptoms: pain, bleeding, exudate, and odor. So when we talk about this wound-associated pain, then we have to listen to our patients. How do they describe the pain? How do they quantify also the pain? And this is a study we conducted in Ireland, where patients impressively were mentioning how they feel wound-related pain, like dart, niggling, or stinging, or sharp knives. So if you do an assessment, please ask always patients how you do and how you describe your pain. So what is pain, and what especially in palliative wound care? First of all, we heard that already from Elena. We have this tissue damage. We have also the inflammation that is there, because most of these wounds are in the inflammation phase. Most of them, and it depends also if there is a tumor invasion, for example, or if they have an underlying disease like peripheral arterial disease, that there is can be some ischemia or poor perfusion that cause hypoxic pain. Then Elena was already mentioning the infection that can be present. Of course, sometimes also biofilm can increase inflammation and nerve sensitivity. Then we have to, Elena mentioned it already, it's not only the nociceptive pain, but we have also a big part of these wounds can have the neuropathic pain. We know from the literature that about 70% of wounds in general have both nociceptive, but also these neuropathic pain. And that means also then afterwards for the treatment that we have to cover both the nociceptive and the neuropathic pain. Then we don't have to forget these wounds can be very exudative. That means we can have a lot of exudate that can macerate and also can damage the peri-wound edges. What we have to think also is the procedural pain during the dressing changes that we give that we take time when we change the dressings, and especially that we give the patient something before the dressing changes. And we know also the psychological distress that we have when, or patients have when we change, for example, dressings. We know, for example, from a study from Kevin Wu from Canada, showing impressively when we do a dressing change and then the patient suffers from pain, that every time that we change the dressing, that the pain can be experienced much bigger. So what are the key considerations for pharmacological approaches to the management of wound-related pains? And this is from the document. So first of all, we have to do a regular, consistent pain assessment. That means we can use these verbal scales, for example. These are the commonly, it's the 1, 0 to 10 or 0 to 100 scale, or also these comprehensive assessment. That means that should include duration, triggers, characteristics, and need for breakthrough relief. But we have to think also of patients that with a cognitive impairment, for example. Here we can use, for example, the ABI scale or the pain AD, that means pain assessment in advanced dementia scale, or we have also the face rating scale. Then, of course, we have to review the effectiveness and the need of the breakthrough analgesia, but also we have to individualize the assessment frequency. And this, it depends also what kind of wound dressing we apply, especially when we have a lot of exudate. Then we have to identify and treat the cause. We heard that already from Elena, from pruritus, for example. And then we have to check if we want to use non-pharmacological strategies first, or we want to use drugs alongside. And I will come back to that just in a couple of minutes. So when we talk about the wound management principles and the wound-related pain in palliative wound, the palliative wound setting. So first of all, we have to determine if a pre-procedural analgesia is required and allow time for administration and also the effect. Please check the manufacturer how long you have to apply this analgesia. Then review also what kind of dressings did you use? Is this still appropriate? And what we recommend in the document that we use atraumatic silicone-based dressing where it's possible, so that we can have an atraumatic dressing change. And of course, you have to manage the exudate to reduce the frequency of dressing changes. Otherwise, we can go back to Elena's presentation where she showed what frequent dressing changes can do. So what can we suggest in wound-related pain? First of all, we have all these on-label possibilities. I don't know if you use EMLA cream in your clinical practice. This we have to wait for 30 to 45 minutes till it's effective. And I don't know if you have the time for that. And of course, if you apply the EMLA cream, what my experience is, sometimes it can get a little macerated. Of course, you can have also the ibuprofen foam that is available on the market, but also the strong opioids like the fentanyl or the fentanyl family. Then the local anesthetics. Here we use most of the time lidocaine and also any systemic analgesic that can be applied. But in palliative care, we use most of the time also the off-label. Off-label, like for example, EMLA cream for patients under 18 years old. Or we can use the topical local anesthetics. For example, also topical opioids. And you have on the right-hand side, you have a mixture that I have taken from one of our publications that is very old already, but it's still valid. For example, 10 milligram morphine in 8 gram hydrogel, but we have to be aware that the physician has to prescribe the morphine gel and the pharmacist should mix this because you change the galenic of the hydrogel. But what else can be done? For example, the topical ketamine, we have very good experience with our patients with topical ketamine, or also the topical sevoflurane. What else can be done in the pain-related, wound-related pain? So I don't know if you use virtual reality. We use that mainly for children. There it works very well. In adults, I have less experience, but I think this is also a good possibility to use the up-to-date technology or the nowadays technology to distract patients when you do dressing changes, especially if you have frequent dressing changes. Let's go over and talk about bleeding. First of all, we have to understand, why does this wound bleed? For example, do we have an underlying tumor below? Do we have fragile granulation tissue? For example, because we have a local wound infection? Or is it due to the inflammation? Or is it traumatically, did we cause the bleeding because the dressing is adhering on the wound bed? Of course, also, how do we cleanse the wound? Do we cleanse the wound aggressively? Do we do a debridement? And especially if patients with a fungating wound, there it's not recommended to do a debridement. And also, do the dressings adhere on the peri-wound skin? So what do we have to also take in consideration? We have to take in consideration the systemic condition. Check if they have anticoagulants or if they have thrombocytopenia. But also, then we have to take in consideration the patient-related triggers. That means, does the patient wear clothes that can give some friction? For example, does it have an etiquette, for example, in the clothes? Or how often is the patient moving? What kind of pants, for example, is he wearing? But also, we have to think and inform the patient if he's sick, for example, if he's coughing, or when we are repositioning the patient, that are all triggers that can cause bleeding. And we don't have to forget the self-inflicted trauma, for example, for scratching the skin when we have, for example, pruritus. So what can we recommend, or what to recommend in the document? First of all, if we have an active bleeding, the first line method is to apply a gauze, for example, for 5 to 15 minutes with direct pressure. Of course, we can also use different dressings. For example, there is this chitosan dressing on the market. We have the collagen gelatin dressings that are on the market, or even the alginate dressings that we have on the market. But please be aware, if we have an active bleeding and if we use an alginate dressing, then it's like you cannot even take the dressing afterwards away because it doesn't absorb the blood. But also, if we have a severe bleeding, then we can take kaolin-coated gauzes, but please be aware, don't leave these gauzes on the wound too long, otherwise it can adhere on the wound bed. This, what we use a lot, is the tranexamic acid. That means this is for the bleeding mainly internally, gastrointestinal. However, we use that with FIS tablets, especially in the home care setting, that informal carers can use that, or the patients, or in the hospital, we can use the ampoules. But also the adrenaline can be used for as a topical agent. But as I said, please use that not too long. It's recommended 10 to maximum 15 minutes. Here, the exudate, we have to also take in consideration the wound-related factors. For example, if we have a high bacterial burden, if we have sloughy tissue, if we have an active infection. Of course, we have also to take in consideration what kind of etiology that we have, if we have a pressure ulcer or a fungating wound, and it depends also the area we have. So what are the systemic conditions that we have to take in consideration? If we have, for example, a patient with a venous insufficiency, with the edema, but we don't have to forget the nutrition, because we know that malnutrition, that delays healing, but it can also increase exudate. Then we have to take in consideration the local factors. That means what kind of dressings that we use, how is the absorbent capacity of the dressings, and of course, how many times we have to change the dressings. This can also increase the wound dressing, the exudate. We have to take also in consideration what kind of exudate do we have. That means what is the consistency and what is the color of the wound exudate. So, what are the key recommendations for the exudate? First of all, we have to do a regular assessment. We have different tools available, like the push tools, the Barbara Bates wound assessment tools, but also when we have when we do the dressing selection. For higher exudate, we take the superabsorbent dressings, but also we can have a first layer, for example, an alginate dressing, a gelling fiber, or we can also use foam dressings as a second layer, for example. Negative wound pressure therapy, we know in palliative settings, and especially in malignant fungating wounds, it's a contraindication. We have to see also if there are fistulas. However, if we discuss that in a multidisciplinary team and we agree to apply a negative wound pressure therapy with about minus 40 millimeter mercury, then we observe the patients, then we can use this negative wound pressure therapy. We don't have to forget to protect the peri-wound skin. And of course, we should minimize the dressing changes. We can also use the bags, from the ostomy bags, for example. I used it only about 5 times in my entire career, because usually these wounds are much bigger as the ostomy bags. But this is also a possibility to collect the exudate. Then the last symptom is the odor. Also there, we have to check how the patient is describing odor. And this is also from another publication of ours, where patients define that it's like rotten flesh, rotten meat, also like old stinky camembert, etc. So what is odor? And this is a publication from our council member, Professor Eva Stürmer, where she showed that the bacteria profiles that we can find about 135 pathogens that were identified that are responsible for odor. For example, the Enterobacter, Staph aureus, Pseudomonas, and Pseudomonas. Of course, we know how this smells, this sweet smell. We have about 180 different volatile reactions there. And of course, the most of the substance groups there identified are the alkanes, are the ketones, and the alcohols. So how can we assess wound odor? And this is a publication from the Journal of Wound Management, where we identify 5 different assessment tools. They all exist in English and not in other languages. So these are validated instruments that are developed and can be used to assess wound odor. But what can we do in the clinic? We have metronidazole that we can use topically. We know in curative wound care we cannot use. Shouldn't use topical antibiotics. However, in palliative wound care, yes, metronidazole, but please do not crush the tablets because it can irritate and increase pain. We have the honey-based dressings. We have also the silver dressings. And of course, we have all the different charcoal dressings that are available. There is also one dressing available with cinnamon that is on the market. So what else can we do? There are studies out with green tea versus metronidazole, and these studies they come from Asia. However, for the environment here, we recommend shaving foam, but also cat litter and different ethereal oils. So I sum up: pain, bleeding, exudate, and odor. We see that it's very common. We have to take in consideration for example, pain, that this is multifactorial. We have to do regular structured assessment. We should use atraumatic wound dressings, for example, but also the psychological burden that doesn't have to be underestimated. We are happy to take your questions, and I hand over to my colleague, Georgina Gethin.
Thank you very much, Elena and Sebastian, for 2 fantastic and packed presentations. Just to remind you, the document is free to download through the EWMA website, so please go to there and you'll find more on each of these. I'm going to go over to 1 or 2 questions, but just to say, it's fantastic to see people literally from all over the world that have signed in. And I know that in many places it's more than 1 person that's there, so it's a fantastic response. And a particular shout out to all my colleagues in Ireland. Great to see you. Just fly the flag. I just have two questions, perhaps, because there isn't a lot in the chat. Elena, I'll go to you first. When people go to treat people with problems in the peri-wound area, they're struggling, they're trying to find the right solutions. And I don't want this to sound negative because people are literally trying to do things well. What is the biggest maybe mistake that people make, or what is the biggest thing that people think is the problem when in fact it's not? Is there something that you often see that perhaps we can address?
This is a very interesting question, and I do think that people think that the more frequent dressing changes we do, or the more we cleanse, and so when we do more, they do think that it really makes a difference. When you are clean too much the skin, you are destroying that hydrolipid barrier, or just putting things on. So when we tell them that make it simple is the solution, using less products to reduce risks of contact dermatitis, or trying not to put things because we are going to get rid of those dead cells that are protecting. So I think that that's the problem that we have in the clinics, yeah. And people associate cleansing with less risk of infection. And in fact, when you cleanse too much the skin, you are destroying the barrier for infection. So I do think that that's the problem, yeah.
Thanks, Elena. Thank you. That's really helpful. And
I
Sebastian,
think
I have
I
a
think
final question for you.
Mhm.
Somebody put it up into the chat that about the use of hypnosis for procedural related pain. And I suppose hypnosis might be the extreme end of the scale, but you've got things
Mhm.
like, maybe distraction therapy and all that. Do you have any experience of that or knowledge of it?
I did hypnosis once in a workshop. I don't use that.
Okay.
But I've seen that at the conference in Paris for the French Wound Care Association, that they use that very commonly. And I don't know, Elena, you studied also in Paris. Um, uh, I think it's something very good. I have no experience in that. The only experience I have is with these VR glasses, and these experiences are very good.
Okay. Thank you. Thank you. Unfortunately, we literally have run out of time. There was one question there in related to epidermolysis bullosa, and I wrongly suggested that it was in the atypical wounds document. It's not, but I do know that Elena and also Kirsty Isherhonen, who is the immediate past president of EWMA, have been doing some particularly literature work on that in the area. And if people want to contact us afterwards, we'll see what resources we can direct them to. But again, it's an area that's probably poorly understood, and there's a huge need for interventions in this area. So I don't know if Elena or Sebastian, you have any closing comments?
My closing comment is that don't have to forget the scope. The scope is to enhance the quality of life of our patients. And that's why we have to listen to the patients, what they want, what is their goal, and not what is our goal.
Thank you. Thank you.
Nothing to add. I completely agree, yeah.
Thank you. Thank you. So thank you to everybody. I said thank you for a fantastic response. And we look forward, I hope, to welcoming some of you to our conference in Bremen in May. And at that, we will have the palliative wound care session again. So thank you all. Have a lovely evening, and we wish you well. Bye bye.
Bye. Thank you.
Bye, thank you.